My talk will focus on the approach to the child who is suspected to have a skeletal dysplasia, the terminology and nomenclature of skeletal disorders, as well as the classification of skeletal dysplasias with some examples of common skeletal dysplasias that we see in pediatrics. So when should you consider the diagnosis of a skeletal dysplasia in a patient? More and more, these diagnoses are being made prenatally. This is typically based on abnormal findings at the 18-week screening ultrasound, unless there is a known family history of a disorder. Usually what is seen are short, unusually shaped bones. Sometimes the bones will already have fractures in them, and the patient may or may not have a small chest prior to birth. This is actually the life-limiting condition seen in skeletal dysplasias. Due to the small chest size, frequently there is lung hypoplasia, and that is why patients are unable to survive much beyond birth in lethal skeletal dysplasias. A skeletal dysplasia should be considered in a patient with short stature, particularly if the patient is disproportionate. And what I mean by that is the spine is more affected than the limbs or vice versa. And I'll talk a little bit about how you determine that. A skeletal dysplasia should be considered in a patient with frequent fractures, particularly if the fractures occur without a reasonable traumatic mechanism. Really, it should be considered in any patient with a significant, such as a femur fracture, without a reasonable traumatic mechanism. Patients who have joint pain without an underlying diagnosis, such as an inflammatory or an autoimmune concern, and of course, patients who have a family history of a skeletal dysplasia. So what are some of the questions to ask on a patient, on the history of a patient that you're considering a skeletal dysplasia? First of all, it's important to know when the manifestations first presented. Some patients, as I mentioned, will present prior to birth with an abnormal screening ultrasound. Some patients will be diagnosed at birth when they are found to be short or have unusual appearance to their bones. And some patients with milder skeletal dysplasias only show manifestations as they grow. This may be manifested by a child who is growing along a growth curve that is significantly shorter than would be expected for the midparental target height, or due to manifestations such as joint pain or other symptoms without a systemic cause. I always ask if there are associated symptoms such as bone and joint pain, which can be common in some of the skeletal dysplasias. Of course, it's important to know if other family members are affected. Many of the skeletal dysplasias are inherited in a dominant fashion, where there frequently is an affected parent. However, many of the more severe skeletal dysplasias are inherited in a recessive fashion where the parents may not be infected. It's very important to understand the inheritance pattern and if there are other affected family members. And then, of course, it's very important to rule out another cause of the symptoms. Chronic illness, of course, can cause short stature and low bone density. Malabsorption can as well. Celiac disease is a relatively common cause of low bone density in children. And, of course, an underlying inflammatory or autoimmune disease that causes an arthritis can lead to joint deformities and joint pain. As far as the physical exam goes, it's important, of course, to measure the patient very carefully and determine if there really is short stature, and then to determine if the short stature is disproportionate. Are either the trunk or the limbs affected more severely? This can be done in a couple of ways. The one that we use most commonly in the endocrinology clinic is to measure the upper to lower segment ratio. This is where you essentially divide the body at the pubic symphysis. So in these patients, I usually measure from the pubic symphysis to the floor to get the lower segment ratio, and then subtract that number from the total height to get the upper segment ratio. The ratio of the two should be around 1, starting by about age 7, but it can be higher when the patients are younger. It can be as high as 1.7 in infancy, usually falling to about 1.3 by the age of 3, and then falling to 1 by the age of 7. If a patient has a significantly higher than 1 upper to lower segment ratio, that indicates that the spine is longer than the limbs and can be indicative of a skeletal dysplasia. Likewise, if the upper to lower segment ratio is less than 1, that can indicate that the limbs are relatively long for the spine and can also indicate a skeletal dysplasia. Another measure is the arm span, which may be familiar as this is frequently measured in patients who are concerned about Marfan syndrome. In this case, you literally measure the span of the patient's arms, which should be roughly equivalent to the patient's height. If it is not, if the arms are significantly longer than the height, that can indicate that the spine is more severely affected and is shorter than would be expected for the patient's height. This measure, of course, is not quite as accurate as the lower limbs are included in the total height measurement, and so they can affect the ratio of the arm span to height. Some other findings that can be seen on exam in patients with skeletal dysplasia. Patients can have a macrocephaly or a large head. This can either be a macrocephaly relative for their small size, as most of the skeletal dysplasias do not affect brain growth, so patients have a normal-sized head on a relatively smaller body. But some patients with skeletal dysplasias can have a true macrocephaly. Patients can also have a frontal bossing, which is a prominence of the forehead. Patients can have a flat nasal bridge, which is a flat part of this part of the face, which I'll show pictures of later. Patients can have craniosynostosis, or premature fusion of the cranial sutures. Patients can have congenital cataracts and vision abnormalities, specifically myopia. Patients can have some palate abnormalities, specifically a high arched palate, as well as a bifid uvula. And patients can have some abnormalities to their mouth, particularly a short and tethered upper lip. It should be noted here that some of the skeletal dysplasias also affect tooth development, so any sort of fragile, broken teeth or unusual shape to the teeth can also be indicative of a skeletal dysplasia. Patients can have some chest abnormalities, which I mentioned previously on the prenatal diagnosis. These can include a long and narrow chest or a very small thorax. This can lead to lung hypoplasia if it occurs in utero, or restrictive lung disease if it occurs later in life. Patients can also develop a scoliosis, which can contribute to the restrictive lung disease. There are some commonly associated findings with skeletal dysplasias. Those include sensory defects. These include defects in vision, whether it be the myopia that I previously mentioned, or other forms of vision loss, as well as hearing loss. Hearing loss is a relatively common finding in several skeletal dysplasias and should be monitored carefully in patients with a diagnosis of a skeletal dysplasia. Patients can have underlying cardiac defects in addition to the lung defects I mentioned previously, and they can also have some gastrointestinal defects. So it's important to examine these systems carefully. The diagnosis of a skeletal dysplasia depends greatly on the recognition of unique patterns of abnormal skeletal ossification. Therefore, X-rays really are the most important diagnostic test for most skeletal dysplasias. This should be done as a skeletal survey, which involves X-rays of pretty much every bone in the body. Some skeletal dysplasias can look quite similar clinically, and the only way to differentiate them is to do radiographs to find small differences in the ossification pattern of the bones. Radiographic appearances of skeletal dysplasias can change with age, and this is particularly true as many of the dysplasias involve the growth plates or epiphyses. As the growth plates fuse as patients go through puberty, it becomes more difficult to see these specific radiographic appearances and make a diagnosis. So getting prepubertal radiographs is quite important to make the diagnosis in many of the cases. What do I mean by a skeletal survey? These are the films that are involved in a skeletal survey at Children's Hospital Boston. They involve an APN lateral skull, an APN lateral spine, an AP pelvis, AP extremities, AP hands, and APN lateral feet. This is a lot of X-rays, and as pediatricians, we are always concerned about how much radiation we are exposing our patients to. This is the one case where I do make an exception. As I mentioned, the X-rays are extremely important for making the diagnosis. So unless it's a very rare case where the diagnosis can be made by clinical exam alone, patients with skeletal dysplasias are likely going to need a skeletal survey. Now we're going to move on just briefly to some of the terminology that you will see in the radiology reports of the skeletal survey. This is an example of a knee radiograph here with the femur coming down and the tibia and fibula below. This space between the bones here and here that the arrows are pointing to is the growth plates. So this is a pediatric patient where the growth plates are still open. The main long shaft of the bone is referred to as the diaphysis, or the primary center of ossification. The end of the diaphysis is referred to as the metaphysis, as shown here. This is perhaps most familiar to pediatricians, as it is the part of the bone that is abnormal in patients with rickets. You hear about metaphyseal widening and fraying. This is where you would see that. After the metaphysis comes the growth plate, and just beyond that is the epiphysis, which is the secondary center of ossification. Once a patient goes through puberty, you get fusion of the epiphysis and the metaphyses and no growth plate. The radiology reports will use each of these features of the bone to describe the abnormalities that the radiologist sees. So for example, if they refer to an epiphyseal abnormality, this means that the epiphyses of the long bones are involved. A metaphyseal abnormality would refer to the metaphyses of the long bones, and the word spondylo refers to vertebrae. Some examples of this are that the patient may be said to have a spondyloepiphyseal dysplasia. This means that the radiologist sees abnormalities of the epiphyses and the spine. A spondylometaphyseal dysplasia will involve abnormalities of the metaphyses and the spine, and a spondyloepimetaphyseal dysplasia will involve abnormalities of the metaphyses, the epiphyses, and the spine. Although each of these categories are relatively broad, for example, there are many different types of spondyloepimetaphyseal dysplasia, it is difficult to make that diagnosis without seeing the x-rays. And once you know the patient has a spondyloepimetaphyseal dysplasia, you can use the patient's other features on exam to guide which genetic testing you request first. The other nomenclature that we use is nomenclature that refers to the limb length, and particularly how the limbs are shortened. Sometimes the overall limb is shortened proportionally, but frequently in skeletal dysplasias, one part of the limb is shorter than the other parts. A classic example of that will be rhizomelic shortening seen in patients with achondroplasia, as shown here. Rhizomelic shortening means that the proximal part of the arm, or the part of the arm closest to the body, is shorter than would be expected for the patient's overall short height, and shorter than would be expected compared to the forearm. Mesomelic shortening means that the middle of the arm is most affected, and acromelic shortening means that the distal part of the arm is most affected. And of course, rhizomelic can also refer to the lower extremities. So in achondroplasia, patients have rhizomelic shortening of both the arms, involving the humerus, and the legs, involving the femur. There are several different ways to classify constitutional disorders of the skeleton, but this is one classification that I prefer. The first classification are the osteochondrodysplasias. Those are the disorders that are involved in abnormal growth, development of cartilage, and bone. Those are the disorders that are going to be the focus of my talk today and include what are classically considered the skeletal dysplasias. A second group of disorders of the skeleton are the dysosteoses. These are malformations of a single bone, hence the name dys, malformed, osteosi, bone. An example of this would be Klippel-Feil syndrome, where only the cervical vertebrae have abnormalities, or different types of brachiodactyly, which means the fingers are affected and are short. Some brachiodactyly are syndromic and are included in other skeletal dysplasias, but there are some types of brachiodactyly where fingers are only affected, making them a dysosteosis. Rare in the pediatric population are idiopathic osteolyses. These are disorders that involve the multifocal resorption of bone. There are also skeletal disorders that are associated with abnormal chromosomes. Perhaps the most commonly known of this in the pediatric population is Turner syndrome, where girls are missing an X chromosome and have short stature. And finally, there are primary metabolic disorders that also involve skeletal phenotypes. The most common of these would be Morquio disease, which is mucopolysaccharidosis type 4. I am not going to discuss anything aside from the osteochondrodysplasias in my talk today in the interest of time. The osteochondrodysplasias can be further subdivided into three separate categories, the first of which is defects of growth of the tubular bones and/or the spine. They also can be categorized as disorganized development of cartilage and fibrous components of the skeleton, as well as abnormalities of density or cortical diaphyseal structure and/or metaphyseal modeling. So first we're going to discuss the defects of the growth of the tubular bone and/or the spine. These can be categorized into 4 general causes. The first are disorders of cartilage. So these can involve the structural proteins of cartilage, either an abnormal quantity, too much cartilage or too little cartilage, or quality, where you have a normal amount of cartilage, but the cartilage that is there is malformed. There can also be inborn errors of cartilage metabolism. Cartilage contains components that have to be post-translationally modified, and this is the metabolism that can be affected by the inborn errors. There can also be defects in the local regulation of cartilage growth, and there can be systemic defects that influence cartilage development, but also cause other syndromic features. There can be molecular defects of the growth and tubular bone of tubular bone and spine due to peroxisomal disorders. Peroxisomes are cellular organelles that are involved in very long-chain fatty acid processing, as well as some other enzymatic reactions. There can be disorders that are due to mutations in transcription factors. These transcription factors bind genes and influence their transcription that are otherwise involved in bone growth and development. And finally, there is a category of disorders where either the cause is unknown, which fortunately that category is shrinking in the era of whole exome and whole genome sequencing, as well as a category, a kind of grab bag category of other genetic defects. So let's briefly discuss the main structural proteins of cartilage. Most of the proteins involved in cartilage are types of collagen. About 85% of the collagen in hyaline cartilage is type 2 collagen. Most of this is encoded by the COL2A1 gene. Type 9 collagen is also involved in cartilage, and there are 3 genes that are responsible for type 9 collagen, COL9A1, 9A2, and 9A3. Type 10 collagen is also involved, as is type 11 collagen, encoded by 2 genes, COL11A1 and 11A2. A non-collagenous protein that is found in cartilage is the cartilage oligomatrix protein. This is encoded by a gene known as COMP, basically an abbreviation of cartilage oligomatrix protein. One of the skeletal dysplasias caused by mutations in the genes involved in cartilage is Stickler syndrome. Stickler syndrome can either be a dominant disorder or a recessive disorder and can be caused by mutations in type 2 collagen genes, type 9 collagen genes, or type 11 collagen genes. Patients typically present with some specific eye findings, including early retinal detachment, myopia, and cataracts, which can be congenital, hearing loss, which can occur in childhood, mid-face development abnormalities, which is basically an unusual shape to the face, as well as cleft palate and the Robin sequence, which involves a very small chin. I will show you pictures of this on the next slide. And finally, patients with Stickler syndrome typically have a spondyloepiphyseal dysplasia and early arthritis. The arthritis symptoms, again, typically occur in mid to late childhood. This is an example of profiles of patients with Stickler syndrome. If you look at the side views of these patients, you'll notice that the middle part of their face seems relatively flat. They don't have a lot of protuberance of their cheekbones, which is typically normal. This is what we mean by mid-face hypoplasia, this very flat profile to their face. In addition, you can see that some of the patients, particularly the girl in panel B, do have a relatively small chin. While this is not the classic anomaly, as it's not quite severe enough, it does show that these patients can have a small chin. One of the more common disorders that I see in my clinic that is usually diagnosed later in childhood, not at birth or prenatally, is multiple epiphyseal dysplasia, or MED. This is a dominant skeletal dysplasia that's caused by mutations in the type 9 collagen genes, the COMP gene, or a related gene known as matrilineal-3. These patients typically present in childhood with pain in their large joints with exercise, usually the knees and the hips. Patients may also have mild short stature. They tend to be short for their predicted adult height based on their parents' height, Although as this is a dominant disorder, it's not uncommon for a parent to also be affected, so that needs to be taken into consideration when calculating their predicted adult height. But they also tend to be slightly short for the general population. Many of these patients actually come to attention because of the arthritis coupled with their short stature. Many of these patients will go on to need relatively early joint replacement in their late 20s or 30s. This is an example of a knee radiograph of a patient with multiple epiphyseal dysplasia. Again, this is the femur bone. These are the tibia and fibula down here. And if you look at the epiphyses of these bones, you'll notice that the outline is very ragged. It doesn't have a nice smooth edge. It appears that there are some changes to the metaphyses, although they're not quite as affected as the epiphyses. This is a common finding in multiple epiphyseal dysplasia. And because, as the name would suggest, multiple epiphyseal, many of the epiphyses in the body are similarly affected, although how severely they are affected and how many are affected does depend on the severity of the illness. This is a relatively severe multiple epiphyseal dysplasia. Now we'll move on to the inborn errors of cartilage metabolism. Perhaps the most common of these is diastrophic dysplasia. Diastrophic dysplasia is caused by recessive mutations in the diastrophic dysplasia sulfate transporter gene, which is encoded by the SLC26A2 gene. The function of this gene is to sulfate proteoglycans that are involved in cartilage. Patients with diastrophic dysplasia have significant dwarfism. On average, their heights are comparable to patients with achondroplasia. They also have significant limb shortening, as well as hitchhiker thumbs, which is an abnormality where the thumb is placed more proximally on the hand. They can have some ear deformities. In particular, they are prone to a deformity known as cauliflower ear, perhaps best known from boxing injuries. This is when the collagen in the ear is damaged and there's bleeding into the collagen, which leads to an ultimate deformity of the collagen. This happens with little or no trauma in patients with diastrophic dysplasia secondary to the abnormal collagen. Patients can have some spinal deformities, including scoliosis, an exaggerated lumbar lordosis, or an exaggerated curve to their lumbar spine, as well as cervical kyphosis. Patients are very likely to develop joint contractures and early osteoarthritis, which is different than patients with achondroplasia, for example. Now we'll move on to the genetic regulators of cartilage growth. These include the fibroblast growth factor receptor 3, or FGFR3 gene. Mutations in this gene are responsible for perhaps the best-known skeletal dysplasias, including achondroplasia and hypochondroplasia. Mutations in this gene also cause a more severe, typically lethal skeletal dysplasia, known as thanatophoric dysplasia. The FGFR3 receptor is a membrane-spanning tyrosine kinase receptor with several different domains. Gain-of-function mutations in this receptor cause constitutive activation of the FGF receptor, and the mutations in achondroplasia and hypochondroplasia are gain-of-function mutations. The normal function of this gene is to negatively regulate bone growth. So if you have overactivity of the gene, you have even more negative regulation of bone growth and shorter bones. What a gain-of-function mutation does is limit the endochondrial ossification, leading to shorter bones. Achondroplasia is the most common form of dwarfism in the U.S. It occurs in approximately 1 in 15,000 to 1 in 40,000 live births. There are about 10,000 affected people in the U.S. and about 150,000 affected people worldwide. Achondroplasia is caused by a dominant mutation, and 80% of the mutations will be new mutations. Like all of the dominant disorders, the incidence increases with advanced paternal age. So a paternal age over 36 is common. Achondroplasia means absent cartilage formation. Patients with achondroplasia have some unique clinical features, including disproportionate short stature. Although these patients are quite short, their limbs are more affected than their spine, which leads to them having a normal sitting height, because a sitting height measures the spinal height. They have rhizomelic shortening of their extremities, which is the proximal shortening that I showed you earlier. And their fingertips typically reach about the level of their hips, so their arms are short even for their height. Patients with achondroplasia have macrocephaly. This can be a true megalencephaly versus a relative macrocephaly for their size. Patients with achondroplasia can have some characteristic facial features, including mid-face hypoplasia, similar to the pictures of the patients with Stickler syndrome I showed you earlier, as well as frontal bossing, which is a very wide, broad forehead. Patients typically have some redundant skin folds on their limbs, particularly in the early childhood period, in infancy and very young childhood. Patients can have what appears to be a relatively well-developed musculature and can have some limitation of their elbow extension, where they're not able to extend their arms the full length. Patients can also have a trident configuration of their hands, where when they extend their hand, there's a persistent space between their third and fourth fingers. Patients can also have bowed tibia, leading to genu varum, or bow legs. And patients can have some joint hyperextensibility, which is typically seen most in young children. What are the complications of achondroplasia in infancy that a primary care provider should be on the lookout for? Patients with achondroplasia are more likely to develop hydrocephalus, so it's very important that their head circumference be followed closely. It should be measured at every pediatric visit in the first year and 1 to 2 times a year thereafter. Some patients with achondroplasia will go on to need shunt placement. Patients can have mild to moderate hypotonia in early childhood, which can lead to delayed motor milestones, and thus many of these patients end up being followed by early intervention. Patients are at high risk of developing otitis media due to poor drainage of their eustachian tubes. This is due to their mid-face hypoplasia, which leads to a more horizontal position of their eustachian tubes and poor drainage. They also can have a relative hypertrophy of their adenoids and tonsils due to their small face and throat size. And almost all patients with achondroplasia snore. Most patients are going to end up needing a sleep study by the age of 4, and most patients go on to need to have their tonsils and adenoids removed. Patients can have some temporal bone abnormalities, and patients can have a very exaggerated curve to their lumbar spine, known as a thoracolumbar gimbus. This leads to the recommendation that these patients be very well supported when they start to sit on their own, and also to the recommendation that patients with achondroplasia not be placed in suspended swings or in the kind of devices that parents wear to carry their children that suspend them without lumbar support. The biggest concern in patients with achondroplasia is apnea. This has been reported to have up to a 7.5% mortality. It's due to several different issues, including their obstructive mid-face hypoplasia, upper airway obstruction, and central brainstem compression with abnormal respiratory function due to foramen magnum narrowing. So 10% of patients with achondroplasia will have craniocervical junction compression with an abnormality within their cervical spinal cord due to their foramen magnum stenosis. Some of the predictors for this finding are hyperreflexia, central hypopnea, and decreased foramen magnum size using the published norms for achondroplasia. Of course, their foramen magnums will be smaller than average size individuals, so it's important to compare them to the published norms for achondroplasia. Due to this risk, as well as the risk of apnea, patients who are under the age of 2 with achondroplasia need to undergo an MRI to look for this issue, which of course can be surgically repaired if needed. Once patients are over the age of 2, if they do not have any other neurologic findings, they do not need to have an MRI, as you would expect them to have had symptoms by that age. Achondroplasia can cause some well-known complications in childhood. Patients with achondroplasia are at high risk for obesity throughout their lifespan due to their small size and decreased energy requirements. Patients can continue to have issues with genu varum or bow legs, and the exaggerated lumbar lordosis, as shown in this sketch, can also be an issue. Patients remain at very high risk for otitis media, which can lead to hearing loss due to chronic otitis media. Therefore, it is important that patients be screened every year. Patients can also develop hearing loss from ossicular chain stiffness or a combination of that with the chronic otitis media. Patients are at higher risk for dental crowding and malocclusion, and patients are at high risk for spinal stenosis, although this typically happens in adulthood, not childhood. The complications in adulthood, as is well known, these patients tend to be quite short. On average, the male height is 131 centimeters and the female height 124 centimeters. There are published growth chart norms for patients with achondroplasia, which should be used when in following children with achondroplasia. Patients with achondroplasia do inherit all of the other height genes that run in their family. So as I frequently tell my families of my patients, if the parents are quite short, you can expect the child to be relatively short for patients with achondroplasia, and if the parents are quite tall, you can expect the child to be quite tall for patients with achondroplasia. Obesity remains a lifelong concern for patients with achondroplasia. Spinal stenosis becomes more of a concern as the patients get older. This can present with lower and upper motor neuron signs, including low back pain, leg pain, and paresthesias. Cardiovascular morbidity and mortality is higher in patients with achondroplasia, and they are at particularly high risk for developing hypertension. Patients can develop complications from their spinal curvature, including deformities and back pain, and they are at higher risk for conditions such as fibromyositis and trochanteric bursitis. The genetic testing for achondroplasia is very, very sensitive because the majority of patients with achondroplasia have a single mutation in the FGFR3 gene. Unlike some genetic disorders, where many patients who are clinically diagnosed with the disorder are not found to have a classic genetic mutation, in achondroplasia, 99% of the patients diagnosed with achondroplasia will be found to have a mutation in the FGFR3 gene, and 98% of those patients will have a single mutation, a glycine to arginine substitution at amino acid 380. The closely related disorder, hypochondroplasia, which is essentially a less severe form of achondroplasia, where patients usually have heights that are between 4 and 5 feet and also have the classic trident configuration of their hands, is caused by a second mutation in the FGFR3 gene. Finally, thanatophoric dysplasia is another dominant skeletal dysplasia caused by mutations in the FGFR3 gene. This is a typically lethal form of short-limb dwarfism. Patients have micromelia, or very short limbs, as well as cloverleaf skull deformity. This is typically diagnosed in utero due to the micromelia as well as the very small chest. The lethality of this disorder is usually related to the small chest size and lung hypoplasia that allows the infant to not breathe on their own after birth. This is also caused by mutations in FGFR3, as I mentioned. Now we'll move on to the systemic defects that influence cartilage development. And the disorder that best represents this group is camphomelic dysplasia. This is caused by mutations in the SOX9 gene. Patients with camphomelic dysplasia have a skeletal dysplasia, but they also have the systemic finding of male to female sex reversal. The skeletal abnormalities seen in camphomelic dysplasia include bowed long bones, as shown on this X-ray here, where the femurs are seen to be bowed. Patients can have the Robin sequence, which includes a very small chin, and pulmonary hypoplasia. 2/3 of 46XY patients will have ambiguous genitalia, although the female patients have normal genitalia and are unaffected, aside from the skeletal dysplasia. Now on to the paroxysomal disorders. These involve the chondrodysplasia punctatas, either rhizomelic chondrodysplasia punctata 1 through 3, or the X-linked form, which is also known as Conradi-Hunnermann syndrome. The rhizomelic chondrodysplasia punctatas are recessive disorders that are caused by deficiencies in peroxisomal enzymes. The X-linked dominant Conradi-Hunnermann disorder is typically lethal in males, so it's mostly seen in females, and it's caused by a mutation in an enzyme involved in cholesterol synthesis. All of these patients have rhizomelia, and typically their arms or the humerus is more affected than their legs or the femur. They also have coronal clefts of the vertebral bodies, as well as cataracts. The reason these disorders are called the chondrodysplasia punctatas is due to the punctate lesions that are seen in their cartilage. This is a film from one of my patients showing the humerus, the radius and ulna, and you can see this stippling or this punctate lesion seen here in the elbow. These disappear as the patients age and get older and go through puberty, so it is important to get a X-ray from a younger time period to make this diagnosis. The disorders that are caused by mutations in transcription factors include the disorders involving the short stature homeobox-containing gene, or SHOX, on the X chromosome and SHOX-Y on the Y chromosome. If you lose a single copy of the SHOX gene, you have a disorder known as Léri-Weill dysosteosis. If you lose both alleles, you have a disorder known as Langer-Mesomelic dysplasia. A second disorder caused by a mutation in a transcription factor is cleidocranial dysplasia, caused by mutations in the transcription factor RUNX2. Léri-Weill dyschondrosteosis is a syndrome caused by the loss of one SHOX allele. It's characterized by a short forearm with a Madelung deformity, which is a wrist deformity I'll show you an X-ray of here in the next slide. These patients can have some limited mobility as well as tibiofibular shortening and short stature. It's thought that the majority of the short stature seen in girls with Turner syndrome is caused by the loss of the SHOX allele. Although the SHOX gene is located on the X chromosome, it is located in the pseudoautonomous region and is not typically X inactivated. In addition, there is a copy on the Y chromosome as well, known as SHOX-Y, so boys also have 2 copies. Girls are thought to be more severely affected by this disorder than boys, and it is a relatively common disorder seen in patients with unexplained short stature. This is radiologic evidence of Léri-Weill dysosteosis. You can see the abnormalities to the forearm bones shown in these X-rays. And this is a Madelung deformity. It's essentially a step off from the wrist. The more severe Langer-Mesomelic dysplasia is caused by the very rare loss of 2 SHOX alleles. These patients have more severe features, including limb abnormalities that include aplasia or severe hypoplasia of the ulna and fibula, as well as a thickened and curved radius and tibia. They can have similar displacement deformities of the hands, like the Madelung deformity, as well as some similar deformities of their feet and hypoplasia of the mandible. Cleidocranial dysplasia, as I mentioned, is caused by mutations in the transcription factor RUNX2. This transcription factor is important for the development of osteoblasts, the bone-building cells. In the absence, when you have a mutation in RUNX2, you get absent ossification of the lateral portions of the clavicles. This leads to patients being able to put their shoulders together in front of their body, as shown in this image. These patients can also develop some wide fontanelles and sagittal sutures with multiple wormium bones seen in their skull. Wormium bones are essentially bones that appear to have worm-like tracks through them. These patients are also more prone to develop low bone density. Now we will move on to the disorders that involve disorganized development of cartilage and fibrous components of the skeleton. I think of these disorders as involving extra stuff where it doesn't belong. 3 of these disorders include the hereditary multiple exostoses. This is a dominant disorder caused by mutations in the EXT1 and EXT2 genes. Enchondromatosis, otherwise known as an Ollier disease, the genetic cause of which remains unknown, involves enchondromas, and Maffucci syndrome is a sporadic disorder that involves enchondromas with cutaneous hemangiomas. Metachondromatosis is a dominant disorder caused by mutations in PTPN11, which involves both exostoses and enchondromas. Patients with hereditary multiple exostoses develop benign cartilage cap tumors known as osteochondromas. This is an example of one seen in a radiograph here. These tumors are benign, and it's typically not recommended that they be surgically removed, as they do have a tendency to grow back. So the patients don't undergo surgery unless the lesions are located in a region that is impairing their movement or causing pain. There is a small risk of malignant transformation of these lesions, about 1% per year over the lifetime, so it is recommended that these patients be followed closely. Enchondromas are benign interosseous cartilaginous tumors, as shown in this finger X-ray down here. As expected, this cartilage, being where it doesn't belong inside the bone, does weaken the bones, and these patients are more likely to develop pathologic fractures through these lesions. Metachondromatosis involves both osteochondromas and enchondromas. Now we'll move on to disturbed bone maturation. This involves fibrous dysplasia of the bone, which is replacement of the bone by dysplastic fibrous tissue. This can either be monoosteotic, involving a single bone, or polyosteotic, involving multiple bones. In patients who have polyosteotic fibrous dysplasia, they should be carefully examined to look for café au lait spots, as well as to see if they have endocrine abnormalities. The combination of polyostic fibrous dysplasia, café au lait spots, and endocrine abnormalities is known as McCune-Albright syndrome. McCune-Albright syndrome is caused by somatic mutations in the GANAS gene. These mutations occur sometime during development when a single cell develops the mutation. Then all cells derived from that lineage contain the mutation. But as it is a somatic mutation, you do not know which cells in the body are affected. The endocrine abnormalities result from the fact that the GNAS gene is responsible for some of the hormonal signaling. Patients are more likely to develop precocious puberty, as well as some thyroid abnormalities, and overgrowth due to oversecretion of growth hormone. These are some films of a patient with polyosteotic fibrous dysplasia. You can see the replacement of the normal mineralized bone by fibrous tissue. As expected, the fibrous tissue weakens the bones, and the patients can develop pathologic fractures through the bones with fibrous dysplasia. There is no medical treatment for fibrous dysplasia. However, for patients who have pain from their fibrous dysplasia, bisphosphonates have been effective at reducing the pain. The bisphosphonates do not slow the growth of the lesions, prevent new lesions from forming, or treat the lesions in any way. They're only used symptomatically to treat pain. In a patient who has monoosteotic fibrous dysplasia or fibrous dysplasia that was found perhaps incidentally by X-ray film, the recommended test to look for other affected bones is a nuclear medicine bone scan. If they are found to have lesions in other bones, they should undergo a full workup, including endocrine screening. Finally, we will move on to the abnormalities of density or cortical diaphyseal structure and/or metaphyseal modeling. This involves the disorders of decreased bone density, the most common of which is osteogenesis imperfecta. Most cases of OI in the U.S., about 95% of cases, are caused by dominant mutations in the type 1 collagen genes, the COL1A1 or the COL1A2 gene. A long and growing list of genes has been found to cause recessive forms in the remaining 5% of the patients with OI. Osteogenesis imperfecta is the one disorder that is not best diagnosed by skeletal survey. These patients are best diagnosed with a DEXA scan to see if they have low bone density, and then if they do, proceeding with genetic testing, or if they are too young for a DEXA scan, proceeding directly to genetic testing. Osteogenesis imperfecta, even the dominant form, comes in several varying levels of severity. The most severe form is the type 2 OI, which is typically lethal. These patients develop fractures in utero and are typically born with a very small chest size and lung hypoplasia, which leads to death. Patients with the more severe form, or type 3 OI, are often born with fractures as well and typically develop bony deformities during childhood due to repeated fractures. These patients are very likely to go on to need growing rod placement in their bones. This is when a rod is placed in many of their long bones to keep them straight that will then grow with the child. Patients with moderate OI or type 4 OI also frequently fracture during childhood, although they typically do not have the same level of bony deformities, but many of those patients will go on to need growing rods and other orthopedic procedures as well. And finally, patients with type 1 OI have the most mild form of OI. Sometimes these patients fracture in childhood and sometimes they do not, but they are all at very high risk of developing early osteoporosis in adulthood. The only pediatric treatment for osteogenesis imperfecta are bisphosphonates. These are typically given after the patients have developed one or more severe pathologic fractures. The opposite of osteogenesis imperfecta are the disorders of increased bone volume or density, and the most common of these are the osteopetrotic disorders. Although these disorders involve increased bone density, the bones are also quite fragile, so these patients are also subject to pathologic fractures. There are multiple genes that are known to cause osteopetrosis. most of which are involved in osteoclast function. Osteoclasts are the cells that are responsible for breaking down and turning over bones before the osteoclasts build the bones back up. One gene that is involved in all the different types of osteopetrosis is the CLCN7 gene, which is a chloride transporter responsible for the secretion of hydrochloric acid by the osteoclast, which dissolves the mineral in bone. Patients with osteopetrosis can have the infantile malignant recessive form. This is a very severe form that is usually lethal if not treated. Patients can also have an intermediate form that typically presents in childhood, usually with pathologic fractures, although occasionally patients are found to have incidentally dense bones on an X-ray for another reason. And finally, the late onset form, which is also known as Albers-Schoenberg disease, typically presents in adulthood with fractures. The malignant infantile osteopetrosis involves osteosclerosis of the whole skeleton within the first few months of life. Patients have macrocephaly, frontal bossing, sclerosis of the skull base leading to choanal stenosis, and as well as possible hydrocephalus and cranial nerve dysfunction. Because of the overgrowth of the skull, there can be compression of the cranial nerves, which can lead to deafness and blindness, usually between 6 and 9 months of age if untreated. These patients also develop delayed tooth eruption, hypodontia, and malformed teeth. The only treatment for malignant infantile osteopetrosis is a bone marrow transplant. As the osteoclasts are derived from bone marrow lineage, replacing the bone marrow will replace osteoclasts. Unfortunately, some patients with malignant infantile osteopetrosis will have a neuronopathic form where they have significant neurologic symptoms, including developmental regression. The neuropathic form of osteopetrosis is not treated by a bone marrow transplant. This is an example of some X-rays of a patient with osteopetrosis. This patient was about 6 months old when these X-rays were taken, and you'll notice how very dense the bones look. The skull is almost white, it's so dense. You can clearly see the outline of every single vertebrae down the spine, which is unusual at this age when the bones are not usually this well mineralized. And similar findings can be seen in the arm, where all of the bones, including the bones of the finger, are extremely well visualized, very unusual at this young age. So in conclusion, I would just like to sum up my talk by saying you should suspect a skeletal dysplasia in patients with disproportionate short stature or abnormalities in their bone structure, as well as patients with increased bone fragility. The first-line testing is usually a skeletal survey, and if possible, this should be read by a pediatric radiologist who is more familiar with looking at open growth plates and the structure of normal growth plates. Genetic testing is available for many of these disorders, but some of the common disorders, for example achondroplasia, can still be clinically diagnosed.